Hello, good afternoon. Welcome to our system-wide grand rounds. We'll get started shortly. Just a few reminders. We will be taking questions throughout the talk, so if you'd like to submit those into the Q&A box or into the chat, either way, those will be monitored, and hopefully we'll have some time at the end to address those. I'm Dr. Francesca Varello-Sims, Director of Education and Training for Baptist and Wilson Children's Behavioral Health. It's my honor to be with you all here today to present this topic on bariatric medicine. We have two speakers. One is joining us remotely, and the other will be speaking live. So our first physician, Dr. Casey Bonnequist, she serves as the medical director of Baptist Health's first medical weight loss program, Baptist Metabolic Weight Loss Clinic. She practices at our Pavilion and Nocatee locations. For school, she attended Nova Southeastern University College of Osteopathic Medicine in Fort Lauderdale, Florida, and completed her medical residency in Lee Valley Health Network, Allentown, PA. Dr. Bonnequist is a board-certified obesity and family medicine physician who treats patients 18 and up. She began her career with Baptist in 2016 at primary care as a family medicine physician. But following her passion for providing effective, evidence-based care to patients struggling with weight gain and obesity, she stepped away from the primary care practice at the end of 2024 to focus on launching Baptist Health's first metabolic weight loss clinic. Our second presenter in the other portion of today's talk is Dr. Craig Morgenthau. Dr. Morgenthau is a board-certified general surgeon who specializes in minimally invasive surgery and bariatric surgery. He completed his surgical residency at SUNY Downstate Medical Center in Brooklyn, New York, and a 2-year research and clinical fellowship in minimally invasive gastrointestinal surgery at Emory University School of Medicine in Atlanta, Georgia. He's practiced at Baptist Medical Center Jacksonville since 2007 as a member of North Florida Surgeons, and in 2008, he helped found the Baptist Center for Bariatric and reflux surgery, which is an accredited center in the American College of Surgeons and American Society of Metabolic and Bariatric Surgery Joint Quality Improvement Program. He specializes in bariatrics, anti-reflux, and general surgery. Welcome, Drs. Bonnequist and Morgenthau. And with that, Clee, take it away. On my end, unable to see the presentation.
Trying to get the sound to share. It's not sharing sound. Give me one
Gotcha.
second.
Wonderful. Thank you. We'll have it loaded shortly, all.
Well, welcome today. We're going to be talking about updates in obesity medicine, and I'm going to be sharing with you the first part of this lecture, which is focusing on medication management. And my name is Dr. Casey Bonnequist. I've been with Baptist, initially with Baptist Primary Care since 2016, practicing family medicine and obesity medicine. And then starting this January,
Having technical difficulties. I'm sorry, it's not playing the sound, but we are going to make it work. Go. Nice.
So, Clee, I also have the talk. Do you want me to try? Because I did it prior and it was able to be heard. Can we try that?
welcome today. We're going to be talking about updates in obesity medicine. And I'm going to be sharing with
I think we got it. I'm sharing, share.
January, we opened up we're going to be talking about updates in obesity medicine. And I'm going to be sharing with you the first part of this lecture, which is focusing on medication management. And my name is Dr. Casey Bonnequist. I've been with Baptist, initially with Baptist Primary Care since 2016, practicing family medicine and obesity medicine. And then starting this January, we opened up the Baptist Metabolic Weight Loss Clinic at Nocatee and downtown at the Pavilion. And so I'm serving as the medical director. And I wanted to take some time to review some of the medicines for you. I don't have any disclosures that would impact this lecture. So our learning objectives for today are to classify obesity as a chronic disease, to identify the goals of medical weight loss, to understand the set point theory of weight and how that can impact weight loss, know the guidelines for medication use, compare the risks versus benefits of medications, and emphasize the importance of behavioral change. So this slide is to remind us to think about obesity as a chronic disease. And that's important for both the practitioner and the patient to think about obesity as a chronic disease because it requires a lifelong effort. So meaning that to sustain the weight loss, we need to give the patient the expectation that they would continue on the medication, that they would continue on the behavioral change, or have a permanent procedure like a surgery. So a lot of times patients will think, let's start on a medicine to just get jump started. But really, that's not setting them up for success. We need to think about it for the long term. So looking at the major goals of medical weight loss, we know that a 5 to 10% reduction in body weight will show improvements in comorbidities associated with weight, like diabetes, high blood pressure, high cholesterol, fatty liver disease, obstructive sleep apnea, peripheral artery disease, congestive heart failure, the risk of heart attacks, and the risk of stroke. And I specifically looked at, highlighted some of the comorbidities that are also, we'll see later down the line, correlate with some of the comorbidities that we can help get our patients approved for medications if they have these certain conditions. And then our second goal is emphasizing that is to be sustained over the long term. So we're really trying to avoid yo-yo dieting in patients because we know that each time a patient goes on an extreme diet, loses weight, then they go back to eating regularly, they have that weight regain and even more weight regain. And then their metabolism adapts by slowing down. so that patient becomes hungrier. They're not able to process foods as well. And so that's not setting them up for success for the long term. We're really trying to look at it as a long-term change and trying to maintain a weight. So when I'm talking to patients about weight, I'm looking and trying to identify, okay, what is that steady weight where your body kind of naturally ends up? It's not the weight that is your goal weight, but it's the weight that your body kind of keeps going back to. So we can see a patient, they really get engaged in a diet and exercise program, and maybe they'll lose 10, 15 pounds or so, but they'll kind of hit a plateau. But on the same respect, if it's, let's say, the holidays, or they really get out of the habit with their diet and exercise, maybe their weight will go up about 15 pounds. So generally, there's a set point or the weight that the body likes to stay at. And so for people that can't get to their goals with diet and exercise, ways that we can lower that set point is through medications or through bariatric surgery. And so I'm going to talk with you more about the medications, and Dr. Morgenthau will review with you later on today about bariatric surgery. But they're both lowering the set point. So a couple of things to think about as we're considering if a patient would be started on medications and what would be appropriate. So first, as we're thinking about the groundwork for starting medicine, we always think about it as an adjunct to other therapies. So meaning that patient should also be making behavioral changes in terms of their diet, exercise, and offering support for coping mechanisms besides emotional eating, and trying to really get that patient into better habits to set them up for success. And so that's why I put a little picture of Richard Simmons there in his unitard to remind us of that. And then, so according to the FDA standards of patients that can be started on weight loss medicines are patients who have a body mass index above 27 and comorbidities. And we had talked about some of the goals of medical weight loss and the comorbidities we can improve on. And so those are what are considered another qualification for starting a weight loss medicine. Or if their body mass index is above 30, regardless of comorbidities, you can start a patient on weight loss medicine. Also, part of the guidelines, and we'll talk more about it, but is screening for contraindications of medicines. In general, that a patient could not be pregnant to be started on a medicine, and also wouldn't set that patient up for long-term success because we'd need to stop that medicine prior to that patient becoming pregnant or considering becoming pregnant. Other guidelines, we reassess the patient after 12 weeks to determine if they're having a response to the medicine, and we consider that response to be a 5% or more in terms of weight loss. So not every patient will respond to every medicine because each medicine works through a different mechanism, and each patient has a different reason that their body is at a higher weight. And then other parts about thinking about medicine use is really getting buy-in from the patient and willingness to be on the medicine for the long term. And a big part, as many of you know, with the GLP-1s, GIPs, is the affordability of the long-term use. So kind of going back to our principle of thinking of obesity as a chronic disease and thinking about that patient being on the medicine for the long term, we want to know that they're going to be agreeable to being on on the medicine for the long term and discourage the idea that someone could be on a medicine for the short term and just jumpstart their weight loss. That would be really not setting them up for success. So I wanted to review, the main medicines that are FDA approved anti-obesity pharmacotherapy. So, looking at this, we kind of starting with what had been historically used, which have been phentermine. And many of you are familiar with that because it's inexpensive. It's been around since 1959. But we really only see a weight loss percentage of about 5%. And that's really, once again, just sustained while that patient is taking the medicine. Medicines that are approved for long-term use include orlistat. And so that came out in 1997. It's not a very popular medicine because basically it makes patients not absorb fat. And so there's fecal incontinence, which is not well tolerated by patients. And we have a pretty low weight loss percentage at 4%. But sometimes that's a prerequisite to being able to start a patient on other medicines. The next medicine is phentermine topiramate, also known as Qsymia. So that's right, combining the stimulant of phentermine and Topamax for appetite suppression. That came out in 2012. And for a long time was really the most effective medicine that we had at about a 9% weight loss. And so that's a little bit better tolerated for patients than phentermine alone because it's in a lower dose, it's extended release, so we can see less side effects. And the affordability is better than the injectables. Our next medicine is naltrexone Wellbutrin, also known as Contrave. And this works best in patients who are struggling with emotional eating, stress eating. And we do have to keep in mind that the naltrexone component will, block receptors for opioid medicine. So if patients are on chronic pain medicines, this would not be the best choice for them. And this came out in 2014, and we can see a 5, sometimes even 7% weight loss with this medicine. Then we get into the class of the injectables with the GLP-1 receptor agonists. And so for initially in 2014, we had liraglutide. And you can see a couple of things to know about it. It's a once a day dosing. And we really just see a 5% weight loss. So then we can really see, major impacts and life-changing with starting the semaglutide, also in the weight loss version as Wegovy, in the diabetes version as Ozempic, which is also primarily a GLP-1 receptor agonist, came out in 2021, and we see a 15% weight loss. So now we're starting to see some clinically meaningful weight loss that can really get people to goal and make it worthwhile to stay on a medicine for the long term. Then in 2023, the FDA approved tirzepatide for weight loss, which was, of course, Mounjaro for the diabetes form, and then Zepbound for weight loss, which has the additional mechanism and is primarily improving the amount of GIP, and in addition to some GLP receptor agonists. And then we can see an even more significant weight loss up to around 20%. So I'm really going to spend some more time talking more specifically about semaglutide and tirzepatide, since these are our most effective current weight loss medicines. So to give you some background on semaglutide, we had talked about it's a glucagon-like peptide receptor agonist. So what we know about the mechanism of action, this will increase glucose-dependent insulin secretion. So having more insulin in circulation. It will slow down the gastric emptying. So that kind of helps us to understand why the side effects profile are like they are. And then that increases satiety. And so that will decrease the patient's food intake. So commonly, we're going to see side effects like nausea, constipation, diarrhea, reflux. Severe, serious side effects would be pancreatitis, the thyroid tumors. Those are seen more in the clinical studies with rodents where they were given high doses than we actually have been seeing in patients. But still, patients should be monitored for their thyroid, and if they notice any enlargement in their neck, any lumps, they should be evaluated. And I like to just also monitor the thyroid, the TSH levels about twice a year, just to make sure there's not any changes there. The contraindication, we had mentioned, of course, pregnancy is a contraindication, but also a personal or family history of multiple endocrine neoplasia. And then to talk more about our other injectable, which is tirzepatide and Zepbound in the weight loss form. So it has the action of the glucagon-like peptide receptor agonist, but it additionally has the glucose-dependent insulinotropic polypeptide. So that's primarily the mechanism. So we had just reviewed the GLP-1 receptor agonist mechanism. So then the additional benefit that we see in Zepbound is through the GIP. And we see a reduction in calorie intake, an increase in glucose and triglyceride uptake at adipose tissue, and an increased insulin sensitivity. So generally, the Zepbound tirzepatide is more effective and also better tolerated. And we think that's because it's spread out on focusing on two mechanisms instead of one. So similar side effect profile in terms of the semaglutide, where we can commonly see the nausea, the constipation, diarrhea, reflux because of that delayed gastric emptying. Typically, I like to monitor patients closely, seeing them once a week, deciding, okay, how are your side effects? Are we going to go up on the dose? Or do we really need to focus on getting this constipation under control before we go to the next dose? So those are some things we balance in addition to, how is the weight loss progressing? So severe side effects are similar in terms of pancreatitis. Once again, the thyroid C-cell tumors were seen in rodent studies. And there's also some concern in estrogen-containing oral contraceptives. So that's something also to be mindful of women of childbearing age, that it could reduce the effectiveness of certain contraceptives. So sometimes, that patient would need to have a conversation with their GYN. Maybe they would consider an IUD or a different form of contraception. It is also contraindicated with a family history of multiple endocrine neoplasias. And then with any of the patients, especially on the injectables like the tirzepatide or the semaglutide, we want to make sure that we're supporting that patient behaviorally, because these are very powerful tools, but we want to make sure that that patient is meeting their protein intake goals to preserve muscle mass. Also engaging in resistance training to increase strength and help preserve muscle mass. Endurance training to increase endurance, because that won't just happen naturally with weight loss. And then this is a picture of our Sika scale that we have. And this is how we monitor body composition. So our goal is really to maintain that lean muscle mass and reduce the fat mass, because that's really what matters for metabolic health. So we're trying to get patients more focused on the protein and on the resistance training to really be metabolically healthier, not just losing weight for weight loss sake. And patients also, that's better in terms of body composition and even cosmetically, but it's most important to us for their metabolic health. So in summary, is thinking about obesity as a chronic disease, and that the medicines and the behavioral changes would need to be sustained for the weight loss to be maintained. And that we know that with a 5 to 10% weight loss, we can see improvements in a patient's lipid profile, insulin sensitivity, blood pressure. We talked about how we can lower the set point with medications or surgery. Medications can augment weight loss for appropriate patients. And we did a little bit more of an in-depth review of the tirzepatide and the semaglutide, because those are our most effective current medications. And then patients should be encouraged to meet protein intake goals and engage in resistance training. So that is a little update on the medicines. I wanted to introduce you briefly to our weight loss clinic. So this is one of our locations. This is our Nocatee location at the health place. I like the patient experience that our patients have coming into the health place. There's also a YMCA here. There's our wellness coaches. And it's really to give the patient the idea and understanding that to be successful in this program, we really need it to be comprehensive. So to tell you a little bit about our mission, it's one, to provide medical weight loss therapies for patients to improve their metabolic health and to reduce the comorbidities that are associated with weight through weight loss. Secondly, we utilize a comprehensive, individualized, evidence-based approach that patients are on board with. And so I think that's important because everyone has different challenges and different physiology that impacts their weight. And we want to use the best evidence for that to have the most improved health outcomes. Thirdly, we want patients with obesity to be treated with dignity through a comfortable and welcoming environment, for that to be accessible in their community, and to also focus on wellness. So a lot of times for patients, they can be intimidated kind of coming into the healthcare system and worried about judgment, but really kind of trying to identify what are their barriers that get in the way, and trying to partner with that patient and make them feel comfortable. And then our last goal is to really be able to integrate and streamline all the different weight management resources within the Baptist Health Network into the department. So our current locations, this is just a map kind of showing the pavilion in the downtown area, and we have a body composition scale there. We have also at our second location in Nocatee, and then we can see patients for virtual visits, and they can also check in with wellness coaches if they needed to do the Sika scan in their local community. And that kind of, so we try not to limit people in terms of the drive, and we can even see new patients virtually. And so patients are asking what to expect at a visit. So typically how I like to start a visit is really, reviewing their comorbidities. looking at conditions and medication that can either, make weight loss more difficult, or that we're looking at improving with weight loss. Hear about their weight history. How much are they struggling with hunger or food noise? What's their current physical activity? What's their current diet? What's been the impact and kind of history of yo-yo dieting? Because typically we'll see a lot of patients whose metabolism is actually really low from years of yo-yo dieting and the metabolic adaptations that go along with that. And then we'll have a discussion with that patient of how they could best be supported. And also, we do additional lab studies, sleep studies. We take a look at the body composition through the CK scan. If patients are a candidate for medications, we can talk about the risk versus benefits. We want to make sure a patient is supported with lifestyle support or surgery if they qualify. So how to get the referral over to us? Referrals are placed through Epic, through our metabolic weight loss clinic. And so this is a little bit of a snapshot. Because technically the way it's set up, you can either choose for the patient to be seen at the Nocatee or the Baptist location. Either one of those will get to us. And if the patient changes their mind, that's not an issue. We see the patient, we bill them through their insurance. So it is an insurance-based practice, and that's based on their comorbidities. And we do have a specialty copayment rate that is collected when we see patients. And then also wanted to introduce you to a comprehensive team. So we have the Baptist Health Center for Bariatric and Reflux Surgery with Dr. Morgenthau and Dr. Hodgett. And you'll be hearing from Dr. Morgenthau shortly. We have our bariatric behavioral health team. So we have our health psychologists, Dr. Webb, Dr. Robertson, Dr. Pagliazzo. We also have a mental health therapist. So that is a big part of our team. We have nutrition services. We have registered dietitians that are downtown and virtual. As many of you may know, unfortunately, insurance does not typically cover dietitians, so it's around a $50 charge for visits, but this was an important part of the program to make accessible for patients. And then we have our healthy living centers throughout the community where patients can also have their body composition measured, their blood pressure, their heart rate. It's connecting patients to the Baptists within their local community. And then we have the wellness program that helps support people through exercise programming, different gym referrals. So that is free to patients. Wellness coaches are free. And then for our employees, we have employee wellness with the wellness coaches, Sika body composition, dietitians, and psychologists, which are all free to Baptist employees. And then our other part of the team is Baptist physician partners. We are working with hospital pricing to make the injectables more affordable for our employees. And so, yeah, we hope that if you have any patients that have any additional needs, we would be happy to see them at the Metabolic Weight Loss Clinic. And now I'll turn it over to Dr. Morgenthau.
Okay, Dr. Morgenthau, the floor is yours.
All right. Hopefully everybody can hear me.
Yeah.
Okay, there we go. All right. Thank you very much for the opportunity to talk today. I enjoyed listening to Dr. Boniqua's talk, and very happy to have her aboard. And so I'm loading my PowerPoint here. It should already be working.
Just taking a moment to load.
Okay. All right, there we go. There we go. All right, so my talk, I'm going to talk about surgery. I'm also going to talk about the medications, and I think there's it's a very exciting time for bariatric medicine and surgery because we now have new tools available as far as the medications and um, you know, we didn't have anything really new over the past few years that made a big difference in patient decision making. So my talk is there a role for bariatric surgery in 2025? And the short answer, and the answer really is yes, but I'm still going to give the talk. So first, I need to mention that I am a consultant for J&J MedTech, formerly known as Ethicon Surgical, and also Moon Surgical, but there's no conflict of interest in this talk and nothing that's relevant. Um, so everybody understands, I believe that prevention is the key. Once the weight is on, it's very hard to lose. And prevention through healthy diet and regular exercise, healthy lifestyle is the key. Once we're at the point of morbid obesity, there's an average of 10 years less life expectancy, as obesity affects just about every organ system. So that's what we're up against. And we've got the different treatment modalities, really medication and bariatric surgery, but whichever of those two somebody chooses, they have to address any lifestyle changes because the efficacy of medicine and surgery will not be as impactful. And so the lifestyle change is key no matter what. Um, and I think when we look at the waterfall plot of just any random study, each of these columns is an individual patient. And we see that in the control, there's patients that lose a lot of weight without anything, presumably a placebo, and some that gain weight. And with an intervention, there should be a shift to that curve so more people are having the desired outcome and less are not. But I think what is important to recognize is that not every patient is going to have the same response to the same treatment. And so we have to tailor our treatment to the individual. So shifting to bariatric surgery, and where are we now, or at least at 2022, which is the most recent data available. In the country, we were at about, and this is for primary procedures, not revisions, about 2/3 sleeves and about 27% gastric bypass. The lap band has essentially phased out, and the biliopancreatic diversion duodenal switch is a more extreme gastric bypass. And so most surgeons and patients are not choosing to do that. You can see there's about a 2.6% penetration into the bariatric procedures. So more about that, but that's not commonly done due to side effects such as diarrhea, protein deficiency, vitamin deficiencies. This just shows graphically over the past 10 plus years the rise of the sleeve gastrectomy. We did our first one here in 2008. And the drop in bypass, although leveling off and now picking up a little bit again, and the band precipitously going down. And all the other ones, there's a few other ones such as gastric balloons, endoscopic suturing, but most of those are pretty minimal. And then the revisions are typically a combination of sleeve or bypass, band to sleeve, for example, or sleeve to bypass. There are a couple of newer procedures that are approved by the bariatric surgical societies, although insurance is still not covering. With the gastric bypass and with the BPDDS, there's that RULIM, and there's two connections or two anastomoses. So the gastric bypass with a little bit longer pouch and with this loop, that's called the mini gastric bypass. Um, and then similarly, where the common channel for absorption of nutrients is about 100 to 150 centimeters with BPDDS, this is now 250 to 300 centimeters. So a little bit improved metabolic or I should say diarrhea and deficiencies, but not approved by a lot of insurance companies. So in terms of weight loss, when we're comparing medications and surgery, this is one study that's representative of the literature, and this shows weight loss outcomes to 7+ years. So typically, so the red is sleeve and the blue is gastric bypass. And this is what we see, and this is what I tell my patients. For gastric bypass, you should lose 30 to 35% of your total body weight, and that should be maintained long term. Yes, you're going to gain a little bit from the bottom, but the large majority of patients will stay in that range. With the sleeve, 25 to 30%, and typically they'll stay in that range. So that's what we're looking at for bariatric surgery, and a little bit more for BPDDS, but again, due to some complications, that's why that's not commonly done. So talking about our program, since 2008, we did 2 cases. We went up to 406 in 22, a little down in 23, and then we felt the medication, so down about 30% or so. But I bring this up to point out that we are an accredited center for the American College of Surgeons and American Society for Metabolic and Bariatric Surgery. And this is a quality improvement plan or program, I should say, that helps to drive outcomes. And so the safety of bariatric surgery is safer than it's ever been. And really, a sleeve or a bypass should be at no higher risk than a cholecystectomy, for example. Okay, and so we submit our outcomes to this database and we can compare to similar institutions, and that drives all of us to get better. This was from the year 23, July to June 24. I mentioned our numbers are down a little bit, but 206 sleeves, and all of our quartile is good. We had no reoperations or interventions, so that was in the first decile. If you have one episode of bleeding, which actually is less than our predicted rate and less than our expected, that puts us in the 7th decile. That just shows how uncommon these events are. So gastric bypass, out of 46 we did over the same time, we had 2 all-occurrence morbidity, none of which required reoperation, and we're in the 1st, 2nd, and 3rd decile. And so I think, over the years, our numbers for bypass have gotten better and better, so I'm very proud of that. The medications are newer, obviously, and so there are studies and the approval trials, but not really the long-term data that you have with sleeve gastrectomy. So these are historical operations starting in 1963, where they went about 40 centimeters down in the small bowel and then hooked that up to colon. And 6 years later, they figured out that wasn't a good idea, so they went 10 centimeters back onto the small bowel. That also wasn't a good idea. So we learn from all these years of research A gastric bypass started out as this loop with a bigger pouch, 1965, and then there was all kinds of stapling operations, and then the VBG in the 80s, and then the sleeve gastrectomy ultimately became, that was the first stage of a two-stage for a biliary pancreatic diversion duodenal switch, and then it became a standalone towards 2005, 2007. Just about the Roux-en-Y, named after Caesar Roux, who's a Swiss surgeon back in 1893. It looks like a Y. You've got your food bypassing your stomach, your digestive juices, and then the common channel where you're absorbing your nutrients. And so years and years of research, many, many studies, and looking at mechanisms of action. When we talk about GLP-1 agonist or dual agonist tirzepatide, those are two mechanisms, and there's 16 mechanisms listed here. Calorie restriction, obviously you're eating less. A lot of these are hormonal adaptations, controlled malabsorption with gastric bypass. But just to make it even more confusing, there's many more mechanisms. We're not even 100% sure of all the mechanisms. This just looks at the impact of gastric bypass on type 2 diabetes and how it does achieve remission in many patients. So the body has all kinds of ways to adapt and all kinds of mechanisms. So bariatric surgery has more mechanisms, and so you have a more powerful impact. A landmark study was in 2004 where they realized that the comorbidities greatly improve with bariatric surgery, and so the name metabolic and bariatric surgery kind of changed. For it was the American Society of Bariatric Surgery, they changed to metabolic and bariatric surgery, and very high number of patients improving or going into remission. We don't say cure because, for example, for type 2 diabetes, it depends how many islet cells producing insulin that the patient has. But there's no question that these operations are life-changing and in many cases life-saving because of the impact on comorbidities, which translates to improved mortality rates. This is a trial from Canada looking at patients that had only morbid obesity. They had no other medical conditions, and they followed them out for 5 years. Their BMI was 50, went down to 33. They had 35% drop in their BMI. And hospitalizations, days in the hospital, doctor's visits, total costs were less in the group that had bariatric surgery versus the morbidly obese controls that did not. And so these are all new onset medical issues. And when you look at, for example, cancer, 2% of the bariatric patients developed cancer over 5 years versus 8.5%. So when you look at all of these medical issues, such as diabetes, which is more common in the control group, the mortality rate was less than 1% in the bariatric surgery group versus 6% in the non-surgery group. So, and that's including a very low operative mortality, which was like 0.1 or 0.15 or something. So this is another trial at the VA where it just shows the curve separating over time between the surgical patients having a lower mortality versus their matched controls. They followed them longer on this study to 10 years. And there were patients that had comorbidities, a little bit sicker. So they had a 24% control rate, and bariatric surgery was 14%. Back in 2015, over 40 societies, medical and surgical, met to review all the data related to type 2 diabetes and bariatric surgery. And it was felt that there was overwhelming evidence that bariatric surgery should be recommended for any patient with a BMI over 40 with type 2 diabetes, and should also be recommended for BMI 35 to 40 with inadequately controlled hyperglycemia. There's a whole body of literature on cancer reduction, 0.72 odds ratio for all cancers, but the obesity-related cancers, 0.55. So different cancers such as postmenopausal breast, colorectal, endometrial, pancreatic. So these cancers all go down. This is from Cleveland Clinic, looking at major adverse cardiovascular events. Here, just looking at the mortality, 10% at 8 years versus 18% in the non-surgical group. And when they look at total weight loss, they're getting to that 25% range with metabolic surgery, with controls maybe 5% or a little bit more. And the hemoglobin A1C, initially that drops down a little bit better than it does in the long term. When you look at durability of remission, gastric bypass is going to have a little bit more durable remission than a sleeve. But so you definitely have to follow them and make sure that they don't go back into type 2 diabetes versus the non-surgical controls that really stayed flat. And then this study just looked at all-cause mortality and heart failure, and you could see the curves favor significantly metabolic surgery, heart disease, stroke, kidney disease, arrhythmias are all less in the group that has bariatric surgery. This study looked at medical issues such as hypertension, both remission and new onset, which favor remission was higher in the surgical group, and then new onset was lower in the surgical group, and the same with type 2 diabetes and hyperlipidemia. Liver disease for NASH went down from 37% pre-op to 3% post-op. So very impactful for liver. And then for kidney disease, renal function is also improved. So the bariatric surgery has this long history. It is safe, it's highly effective, and very well studied. So medications, let's talk about medications. And really the reason that I'm giving this talk is because of the newer medications, semaglutide and tirzepatide, now getting pretty high weight loss. Okay. I think we also have to realize that in these studies that are very well controlled and patients are getting the best care and the best follow-up, they're going to have a little higher weight loss, especially if you take into account the patients that discontinue. But there's no question that the weight loss is significant with semaglutide and tirzepatide. This just kind of talking about the different percent reductions in the different medications, and more patients are going to have some outcome, and less are going to have that really good outcome, and patients respond differently. There's going to be more medications that come out. The retatrutide is a tri-agonist, and they have a higher number of patients getting that over 25% total body weight loss, and even a low percentage getting to 30%. Orforglipron is an oral agent for people that don't want shots once a week. The semaglutide really doesn't have that absorption and that efficacy. So that's what this addresses, but not getting quite the same as the subcutaneous injection, mostly around that 15% range. Looking at cost, now I think that this study, even though it's November 2024, is already somewhat dated, because this was looking at the monthly cost of semaglutide at $1,700. So having that downward pressure from tirzepatide, I saw recently that Eli Lilly and Novo Nordisk both have a $499 self-pay coupon plan, which includes Medicare and Medicaid. So that's still very expensive. These surgery estimates for the cost was inflation adjusted from 2015 rates, still about accurate. But with these numbers, they're looking at the cost of medications favoring the bariatric surgery. It pays for itself in less than 1 year. So the cost may have come down. I think the point is that you're on the medications long term, and that's a long-term cost as opposed to one upfront cost that should pay for itself. This study did not include the downstream medical impacts and the costs related to that. So we don't know about the comorbidities. I think very important, $499 is expensive, and many patients don't have access to that. Similar to metabolic and bariatric surgery, patients need access, and patient preference factors in a lot, clearly. So we're not pushing anybody to do one or the other, just to be aware of what the options are. So I think patients should do what they are ready to do. Um, I just want to talk a little bit about side effects and weight regain, and I'm going to use the STEP trials, the semaglutide treatment effect in people with obesity trials, just to kind of quickly go over side effects and weight regain. So this was the STEP 1 trial, which was obesity, placebo versus semaglutide. And so just looking at nausea, diarrhea, vomiting, constipation, dyspepsia, abdominal pain, 44% nausea versus 17%, diarrhea 31 versus 16. So these are all a little bit higher in the semaglutide group. This is the 2-year follow-up of that trial, and similar differences in what I just mentioned. Here they talk and they add in flatulence, gastroenteritis, decreased appetite, belching, which are a little bit higher in the semaglutide group. Not surprisingly, that there's decreased appetite if you're getting a weight loss drug. And this just shows how most of the episodes of these symptoms are mild to moderate and tend to be at the early phase of medication introduction. Maybe constipation, you're eating less. I mean, maybe it's going out a little further. So, but most of them are mild to moderate and just at the beginning. So this is the SURPASS trial that looked head-to-head tirzepatide and semaglutide, and the adverse events, according to this, were similar, although the serious adverse events were 5.3 to 7% in tirzepatide and 2.8% in semaglutide, so a little bit higher. And I would expect that because it's a little more powerful medication. Um, One limitation of this study was that they only used semaglutide to 1 milligram. So in terms of weight loss and side effects, maybe underestimating that 2 or 2.4 milligram dose. And I mentioned the serious adverse events, and the side effects are pretty similar. So thyroid cancer is something to mention. In preclinical rodent studies, there was thyroid cell hyperplasia, C-cell tumors, medullary thyroid carcinoma. So in observational studies in humans, there were some studies saying there was an increased risk of thyroid cancer. Others found no association. So there is a warning for patients that have medullary thyroid carcinoma or history, family history, multiple endocrine neoplasia type 2, to not use these medications. And of course, further research is needed. As far as vision loss, this is one that we've heard about as well. NAION, non-arteritic anterior ischemic optic neuropathy. This study looked at patients that took semaglutide that were diabetic versus a non-semaglutide anti-diabetic medication, and 9% had vision loss with NAION versus 2%. So that's not insignificant for overweight obesity, where probably they're starting with less potential eye issues, 7% versus less than 1%. So I have seen another study that said there was no difference. I think this was a pretty good study out of the Harvard system. And in any case, additional study is needed to assess causality. But something to keep in mind. And on the one hand, I don't want to bring this up and be fear mongering, but I think it is worth mentioning that in the clinical trials, these are hundreds or maybe 1,000 patients, but when we put this in the real world and there's hundreds of thousands or millions of patients, it might take time to fully understand the side effects. So Belviq was introduced in 2012, and they saw that there was a higher risk of cancer, 7.7% versus 7.1%. And so in 2020, 8 years later, it came off the market. And so I think, more information to follow about all these medications, but hopefully the mortality rate is improved with the improvement of those comorbidities, but just something to keep in the back of our mind that this is an ongoing question. So as far as discontinuation of patients that are taking the medications, at 12 months in this trial, there was 36% of patients that had type 2 diabetes discontinued at 12 months versus 50% that only had obesity. If they had both, it was closer to the type 2 diabetes. So I think maybe the diabetics are willing to put up with more in terms of side effects or the need for the medication. So maybe that's why the obesity only had a higher rate of discontinuing. Another study showed a much higher rate of discontinuing, 71% at 12 months and then 85% at 24 months. So I think that it's important that patients get the best chance to get the most out of the medications in a program where they're getting their side effects addressed and managed, and they're working with dietitians and maybe psychologists as well, because we really don't want to waste our healthcare dollars. And I think in terms of cost, the cost should come down. 2031 is when the subcutaneous or IV formulation of semaglutide will be generic. So 2031, but we still need to get the prices lower. This is another step trial. This was the step 4 trial where they had a 20-week run-in, and then part of the group of patients switched to placebo, and then others continued semaglutide out to 68 weeks. The group that switched to placebo, they lost about 11% of their total body weight, and they gained 8% of that back. And the group that continued semaglutide, they gained 7% back, and the group that continued semaglutide, they lost 8%. Showing that again in this step 1 extension trial, this was the one where they took the placebo out to 68 weeks versus a semaglutide, and then in both groups they stopped, and you could see this steep gain in weight out to 120 weeks. So patients that were on the semaglutide gained 2/3 of their prior weight loss and had similar impact on their cardiometabolic variables. So really, we understand that obesity is a chronic disease. The medications aren't changing your biology, and ongoing treatment is necessary. In terms of comparing medications and surgery, GLP-1 receptor agonists, now I should point out that there's liraglutide in this. I don't see semaglutide, so there might be different outcomes when we look at the newer GLP-1 and dual agonists. But for this trial, there was a lower mortality in the surgery group at 1.8% versus 5%. And this is in the less than 10-year diabetics. So for over 10 years, there was significance, but not an additional statistical modeling, but a similar spread, 4.8% versus 8.4%. Probably if they had more patients, that would have been significant. And this just shows what I just mentioned in the mortality rates, but the weight loss from baseline down 24% for BMI versus GLP-1 receptor agonist down 7.5%. Over if they've had diabetes longer, they had a little bit less weight loss in both groups. This is just another trial or meta-analysis looking at the available studies, medications versus surgery. There was 29% less cardiovascular events, MACE outcomes for bariatric surgery, 25% reduction in mortality. So to summarize, when we talk about weight loss, I think 20% is ideal with the medications. I don't know that that's true of every patient due to patients discontinuing for whatever reason. This one talks about percent excess weight loss. We've tried to switch to total body weight loss for the bariatric surgery literature. And so 30 to 35% total weight loss, up to 66% weight regain, and 7% total body weight regain long term. So continual usage for medications, one-time procedure for bariatric surgery, ideally. Some patients do need revision or conversion. Limited long-term data on safety, and then versus surgery, actually 60 years, and as safe as other common general surgery operations. Mortality rate and medication, or sorry, and comorbidity impact, all significantly favored for bariatric surgery. So again, semaglutide, tirzepatide have good weight loss, improved comorbidities, and less upfront risk, but they're expensive, recurring costs. So there's not really data about tapering and stopping medication or microdosing to try to maintain weight. But I would counter that and say, for example, for other chronic medical issues, once you get their medical issue controlled, we're not just going to take them off antihypertensive. I mentioned earlier about the cost coming down. It would still take $280 a month to break even with bariatric surgery. So anti-obesity medications, they're a treatment, they're not a cure. When you take the medications away for whatever reason, the disease comes back. So also, clearly, metabolic bariatric surgery, it's not a cure, but it's a tool that keeps effectiveness in the long term, as long as patients stay focused on healthy diet and exercise. And that's the point of the accredited center, and then following up with us. And if they have any weight gain or anything, then they need to come back. I don't want to say that there's no utility in medications. That's ridiculous. And I think it's a new tool, and it's exciting to have this available for patients and also for bariatric surgery patients. And we should understand that morbid obesity is a lifelong disease, and there will be some weight regain, but not to the extent of somebody that completely regains their weight, or if they have inadequate weight loss. So we're looking at people, we're following them, and we're trying to give them more intensive follow-up if they're not getting the weight loss outcomes that they should have if they regain weight. And so this might be about 30% of patients that we really need to see back in our program and address any potential issues. So we do not want them to gain weight and have their medical problems come back. So the first thing we're going to do is optimize diet, lifestyle, psychological changes, and before we add medications, also making sure that checking medical issues, making sure there's not an anatomic reason why they are having weight regain. So the term adjuvant and neoadjuvant, similar to oncology. So adding medication to augment weight loss depending on where people have their nadir. So when they plateau, and if they still meet criteria for obesity medications and they want to do more weight loss, then starting medication at that plateau will drive them to the lowest weight. We don't want to wait until they regain weight. We want to drop them down even further. But a lot of patients plateau, following up with a dietitian, using the body composition scale, and working and trying different things, they might be able to get additional weight loss even without medications. So this just looks at the use of the term adjuvant and neoadjuvant for medications, weight loss medications, in conjunction with bariatric surgery. And this is very early in the study, but which combination of medication should we use to get the best outcome, and more on that to come in the future. This is just one example of a study looking at semaglutide or liraglutide for patients that have weight regain. They had 6 months of GLP-1 agonist, and the semaglutide had the most weight loss, 5% weight, 10% weight loss over 15%. So I think that obesity is not going away. It's going to get worse before it gets better. We know this. We've all seen the obesity maps of the United States from 1990 to 2030. We're looking at morbid obesity, which is now about 10%, going up to 20% and higher. And there is a dip in bariatric surgery now, but I think there is going to be a greater awareness of all treatments. And there is a role for bariatric surgery. And so, from a macro perspective, to address the public health care crisis, we need to address the root cause of obesity and preventive strategies, and then align insurance reimbursement with high quality, effective treatment so that our patients get access to metabolic bariatric surgery, anti-obesity medications, and get the support they need with dietitian and psychological help. So again, to summarize, yes, there's a role for bariatric surgery in 2025 and even 2031 when semaglutide is generic. It's the gold standard for weight loss, improvement of comorbidities. It's the most cost-effective and has the most impact on mortality. The meds are a new option. They're not a replacement. I think understanding that, what do patients want? Where are they now? That's going to change over time too. Some patients, they're ready for meds now. They're not ready for bariatric surgery, but that might change. So over a lifetime, many patients are going to benefit from both medications and surgery. And the best option is to have a comprehensive program where we can discuss all options and individualized treatment. And that's part of our bariatric program. And Dr. Bonnequist mentioned that we're going to be happy to help and really partner with primary care as much as possible to get the best outcome for our patients in our community. And I thank you for the opportunity to present this.
All right. Thank you so much, Dr. Morgenthau, for your time. Since we are at time, I saw that your office manager was collecting some of the questions that came through, so we'll get those to you all. We can post them right to the same Teams webinar chat. I have put the CME eval in the chat as well for you all. We'll get your credits assigned as soon as possible, but thank you again to Dr. Morgenthau.
Do we have time to answer questions?
Yeah. If you would like, I just wasn't sure since we were at time. There were a couple. Let me pull them up here. One was related to Dr. Bonnequist, but you guys are in the same domain, so perhaps you can answer it. So what is a protein recommendation for weight loss using medications? Is there such a thing as too much?
So I think when patients have surgery or if they're taking the medications, there's a little bit of a danger of losing muscle mass. So you're losing weight, you're not just losing fat, and it's very important to get adequate protein, let's say 60, 80, I would say even higher, 80 grams a day, let's say, and do muscle work. And I think the body composition scales are very helpful in tracking that. Patients, it's very hard to regain that muscle mass after you lose it. So that's kind of, I guess, a brief answer.
Okay. The next question, if a patient has exocrine pancreatic insufficiency and requires medication, and in parentheses they said Creon, with meals, does this exclude them from taking GLP-1 medications?
Yeah, I don't see why that would. I mean, this isn't like orlistat where we're trying to inhibit pancreas. The mechanisms of the medications working are working differently. I don't think that I don't know. I mean, that's a good question. I have no idea, but I wouldn't think that it would be contraindicated.
Okay. And then the final question that came through, there may be others that are going to populate later, is if one uses medication or even for the bariatric surgery and has a significant amount of weight loss, what would they do for skin removal?
So for bariatric surgery, for example, we want our patients, I've had patients lose weight out to like 2 years plus. So you want to make sure that you're at your kind of final plateau. If you want to lose a little bit more weight, if you want to go on medications, if people are getting better at healthy diet and exercise and they continue to lose weight, you don't want to do the operation and lose more weight because the cosmetic outcome's not going to be as good. So you got to be at that plateau, I would say, for a good 6 to 12 months. And the fact that you're losing weight is a good thing. And I think the excess skin, it's very hard to predict. It depends on how much weight you lose. And if somebody has a pannus, when they come into the office, they're probably, if they have good weight loss, they need to have a paniculectomy. So I think first we focus on getting the weight off because that's what's going to impact their health and wellness. And then where excess skin is an issue, we can use terminology so that it's medically indicated, whether back pain for breast or skin fold, repeated skin fold irritation, infection, despite topical creams, powders, nystatin, etc., supporting garments. So then there's many patients that could get it covered through medical indication. Now, whether everybody can have that covered, I don't know. But the bariatric surgeons that we work with, they do a fair amount of their stuff as an outpatient, and they work with patients to get a fair price. And so it's very hard to predict how much weight they lose, their skin elasticity. So that's that.
Yeah. Okay, well, thank you again and appreciate your time. Please let us know if anyone has any follow-up questions and we'll get with Dr. Svanekvist and Morgenthal. Have a wonderful afternoon and weekend, everyone. Bye-bye.
Thanks y'all so much.
Bye.